Hello everyone, welcome to today's ARIS webinar. Thanks Dr. Ahmed Abyad from Beirut Arab University, who will be our speaker today. Our topic will be of 4 digital tools to alter your patient's smile virtually, quickly, and repeatedly. Thank you, Dr. Ahmed, for accepting our kind invitation to this webinar today, and we wish you all of our viewers knowledgeable and amazing lecture. Thank you all, and Dr. Ahmed, you can start.
Okay, thank you, Abanob. First, I would like to thank the IADS for the invitation. I appreciate the effort being exerted here, to get this educational material out there. Especially that most of the similar continuing education seminars, are reserved to closed societies. I mean, I believe in the accessibility of learning, and I think this material should be accessible to dental students and also to those who graduate who cannot find such materials. You are creating, I think, something like an accessible library of seminars and educational materials. I've seen part of it on YouTube, and I think this is a great cause. I believe that there should be accessibility for such material, and I believe you are doing a great job on that, so thank you for this. I would also like to commend the LADS for their efforts on various events that have been conducted here in Beirut, and taking their own personal time for that cause when they could be doing other things in that time. So with that being said, the presentation is 4 digital tools to alter a patient's smile virtually, quickly, and repeatably. I'm a senior lecturer of dental biomaterials at Beirut Arab University. This is me here in the postgraduate clinics. You might think that dental biomaterials is far from the topic of our webinar, but I might get to that later in the presentation. So, Beirut Arab University is one of the old universities in Lebanon. 4 campuses. Actually, the Faculty of Dentistry is in the Beirut campus. The Faculty of Dentistry has been awarded the leader status by the Association of Dental Education in Europe. It's a great place, in my opinion, to study clinical dentistry. So many equipment, so many pieces of technology, and that's what I personally enjoy. Many of you, I think, came to the mid-year meeting in Beirut, which took place. Some of you visited the university, and I invite the rest to come here. You are more than welcome. So, in this presentation, I'm going to present to you 4 tools for you to perform a smile simulation. So, the 4 tools will put the world of smile design in something similar to a box for you to use. But basically, you have to open that box and try out those tools for yourself. So I think this requires some practice. So I'm hearing my own echo. If we can just fix that, please.
Basically, you have to open that box and try out those tools. I think this requires some practice. So I'm hearing my own echo. If we can just fix that.
Okay. Thank you. Thank you for the help. So, what to expect from this presentation? First, I'm going to explain a key part of the presentation, which is understanding the difference between smile design and smile simulation. It's a very important point to understand because many people confuse the two and end up performing a smile design when they mean to perform a smile simulation and vice versa. So it's really important to understand this point. I'm going to present to you two cases as well where I've used this technique, and you can see how it worked out. During the clinical pictures which are going to be presented, I will have to go slightly off topic and explain some notable clinical features, because the pictures are really nice, I must say. Some pictures are really nice and they demonstrate certain clinical protocols or things that I think should be said. So excuse me if sometimes I go off topic to explain some of the pictures which are shown, but I will have to do that. In the end, I'm going to summarize those 4 tools and show you how they work. But eventually, as I've said earlier, practice is really important. So all I'm trying to do is point out 4 things you can do to perform a really nice smile simulation. But to do that effectively, you are going to have to practice those tools. So regarding the first point, I've said that we need to differentiate between the smile design and smile simulation. Now, a smile design is basically the planning part of your work. So a patient wants to undergo a full mouth rehabilitation, and you want to plan that case. You want to plan that case from an aesthetic point of view. You want to create a smile which is suitable for that patient's face. So you get all of these lines, uh, circles, curves, and you start to put them on that patient's face according to certain rules. And you are able, by doing that, to decide on the proportions of the teeth and their shape. All of this is done for the dentist's sake. So when you do all of this work, you draw the interpupillary line, draw the face midline, draw the teeth midline. All of this is planning performed to help you execute the case or execute the clinical case. I mean, to do it well. All of this eventually is for the dentist. That's what I mean to say. However, the patient doesn't care about all of those lines you are going to draw. If you show this picture to a patient, he's not going to care about it. Patients usually ask for a smile simulation, so they want to see what they are going to look like before they begin the treatment. And sometimes they want to see different different outcomes or different shapes of teeth on their face. So what you do is that you get a template, and you use this template, which is based upon the smile design that you've performed, and you just fix it on top of his original teeth. So the template, or the template work which comes in the end, is the smile simulation, when all the planning which happened before of this is basically the smile design. It's really important not to confuse the two, because usually people use the term smile design for everything. And in many cases, working with templates does not work. And the patient wants to see, for example, how he would look after a certain procedure. And you need to show him this procedure. But if you are only working with a template, it's impossible to do that. So this approach is usually directed towards full mouth rehabilitations or veneers and crowns. What if the patient wants to do partial composite restorations, for example, like a class 4, maybe you want to design it, maybe you want to see, or maybe he wants to see how it would look like if it's fixed. What if you want to simulate an enameloplasty, for example, and fixing the incisal edges of the teeth? How can you do it if you only have a template? What if you want to simulate gingivectomy? Gum recontouring, how are you going to do that with a template? So again, the key point right here is to understand that this approach of using traditional smile design protocols followed by a smile simulation using a template is made when the patient requires maybe 8 or 10 veneers, or veneers and crowns in the upper arch, for example. You could use this template. In other cases, you need something else. Smile design traditionally have been used and performed using simply a paper and a pen. It doesn't need sophisticated software or sophisticated things to perform. But of course, because we have computers right now and we have certain handy software, some are using Microsoft PowerPoint, others are using Keynote. Of course, others are using as well Photoshop. So when it comes to the smile design, the method is not really what's important. What's important is the knowledge that you have in terms of smile design principles and the way that a smile should be designed, as well as your execution for this smile design plan and the ratios and measurements which you get in the end. That's what you care about. If you know how much your central incisor should be in length and width, and you have those measurements, you can transfer those marks to the dental technician and he will perform his work. This is called a 2D smile design, of course, and it's not a 3D smile design, because there's no method or there's no way to make sure that what you are designing is being replicated in the lab. Of course, to do that, you need a 3D smile design. Now, of course, I've been talking about the software, and when you talk to people who do lots of smile design, lots of smile simulations, they are going to usually really like their software or their method. Their method is going to be something sacred to them, very similar to the arguments which you hear between people about Apple and Samsung. I'm sure many of you have heard your friends argue about phones, which is better, Apple's better, Samsung's better. You hear this this argument a lot, and then you really start to wonder why people argue about such a thing. Both phones can perform really well, but you feel that there's some sort of fanaticism when a person is talking about his Apple phone, or when another person is talking about his Samsung phone. He tells you this is the best phone in the world, and also the Apple user who's arguing in that case would also say he has the best phone. He's so attached to that piece of equipment. Although I might argue that maybe an Apple user have not used a Samsung phone before, and vice versa, and yet still they still argue with each other so heavily during that argument. And it was so intriguing to me, and I wanted to know the reason for this. So I thought to myself, why would I argue about such a silly thing? Sometimes it's a really heavy argument, and eventually I came to the conclusion that it's the person's ego. It's the person's ego. People like to feel that what they are using is the best thing ever. Everyone has this feeling. He wants, when he starts to work with a new method or a new equipment or a new technology, this technology is going to be the best technology on the face of Earth. I think that's the problem usually with these kinds of arguments, which also happen when we talk about smile design. Every single person has his method, and every person thinks that his method or his software, when it comes to commercial software, this software is the best software ever. I hear that a lot. So in this presentation, I will not be discussing dental commercial software. I will be discussing other pieces of software which are readily available and everyone can use. As for commercial software, you can do your search on that and have a look for yourself, but I'm just going to give you an overview without mentioning names. So I've just discussed the smile design. And when it comes to the smile simulation, what you are going to do, you are going to take the templates, which sometimes, for example, are oval. Other times you have different shapes of templates depending on what you are actually using. And eventually you use those templates to perform the smile simulation. So again, here's the problem with templates. You have these set of teeth, the sets of teeth, and you need to align those sets of teeth to the patient's original teeth. Again, simulating a veneers treatment or a crowns treatment, but not simulating a gingivectomy, not simulating an enameloplasty, not simulating a simple composite restoration. If the patient wants to see one of those treatments before he starts, you cannot do it with a template. I know some people who simulate a gingivectomy, so for example, by using those templates and putting them on top of the patient's original teeth and moving them a little bit apically or vertically to cover some part of the gingiva and show it to the patient and tell them, okay, so here's what a gingivectomy is going to look like. And the patient is going to be slightly confused because he can see that there are other teeth over his original teeth, and that's not what he asked for. He simply asked for a gingivectomy. You know, the DSD utilizes, or the DSD protocol by Couchman, they utilize PowerPoint or Keynote to align those templates. And there's a much better way to align things in the world, and that's Photoshop. PowerPoint is considered slightly primitive when it comes to alignments and layering a template on top of the teeth. When, in my opinion, I guess the Adobe Photoshop is considered the most powerful tool to align things on top of each other. And this what you see on the screen right now is the best proof for that. This is done on Photoshop. On PowerPoint, it would look really weird. So this is where the PSS concept came from, the Photoshop Smile simulation, utilizing Adobe Photoshop. Of course, McLaren and his colleagues, they utilize Photoshop for smile design, and they have their own method and their own published article about smile design. You can refer to that if you want. The goal of utilizing software in this case is simply to perform the smile simulation in a simple way rather than a complicated way using many layers and masking tools. So I will come to the problem of the complications which happen with Photoshop usually in a moment. Photoshop is considered to be a really complicated software for a regular dentist, but I will try to show you simply why sometimes it doesn't work and sometimes it can work. But first, I want to show you clinical this clinical case. Mira, the beautiful patient, she came seeking an aesthetic treatment, only 2 restorations. She came to the clinic and she had erosion on her anterior teeth, the 2 central incisors. And after history taking, it appears that the problem is a habit of eating a lemon, just putting a lemon there and eating it. This caused erosion and appearance of the dentine layer, and the lesion is growing really quickly. So we need a treatment right here. But Mira wants to see the final result before she even starts. She wants to bleach the rest of her teeth, and she wants to see, with 2 restorations on her centrals, how she's going to look like. The picture you see on top is simply just after Profi-Jet and sandblasting, and this was not prepped. It appears that the tooth is already prepped. You can feel that there's a finish line right there, but that's only because of the habit of lemon eating. It erodes the dentine much faster than the enamel, and you see some sort of a shelf, and you feel that this is prepared, but this is not prepared. So Mira wants a smile design. You are going to directly think of Couchman and his method of digital smile design. So if you apply this method, here's what's going to happen. Of course, you will first draw your lines, the interpupillary lines, midline, etc. But right here, I'm going to zoom on to the teeth, and I'm going to show you the simulation directly. So you have the template, and finally, you just fix or put the template on the teeth. This is the template right from its folder. It's dark, and it's not aligned. So of course, you are going to align the teeth individually one by one, and you're gonna put them there. But after you put them and you show Mira that picture, she's going to be slightly confused because she said she wants 2 restorations, and now you have 8. So obviously you are going to remove them and just put 2 central incisors. Now, right here you find a very big issue which happens in most people who utilize this protocol, especially in PowerPoint. The problem is usually the necks of the teeth, which are impinging on the upper lip. So if you have a gummy smile, no problem. The necks of the teeth will act or will simulate a gingivectomy. But if you have a patient who has a regular smile, the lip is not stretched out so much, you have the neck of the teeth impinging on the upper lip, which seems really weird. So when the patient sees this picture, he's going to feel that, okay, something is not right here. So Mira gets angry and she's asking about bleaching the rest of the teeth. You did not perform the bleaching. So again, with the DSD protocol, to perform the bleaching, you will have to put the templates back again, because there is no way to just lighten up the teeth only in PowerPoint. you will have to put the templates back on to simulate a bleaching. So she's not happy, obviously, because this is a failed smile simulation. You were not able to simulate the results accurately. So when it comes to the software which is available, we have the either or dilemma. So the either or dilemma is basically you are either going to get the box on the left or you are going to get the box on the right. You are either going to get a software which includes really professional tools, but the problem is that it's really complicated. The other option is a software with limited tools, but is simple and could be used more easily. You know, an example for a software with limited tools and simple working protocol, you have PowerPoint and Keynote. An example for a professional software with a really complicated interface, that's going to be Photoshop. Of course, you are going to get lost. The simple software does not give you what you need, and the complicated software is so difficult to operate. With the PSD technique, we fall into the problem of you know, just using templates for some people in Photoshop is common. Some people do that, and others they use the original texture in the teeth and inside of the software to copy it and to, for example, flip one central incisal to another and align it with the rest of the teeth. But you know, I've looked into the technique, the PSD technique. It's really nice. You can have a look at it. Its problem is the complication. So it's a complicated software for someone who is new to Photoshop. What I really appreciate about those two protocols by Edward McLaren and Christian Caltron, so the DSD protocol and the PSD, especially regarding the DSD, is that it introduced smile design to many people who did not perform it before. Because they are using such readily available software, because they are using PowerPoint, which is on the laptop of every person on earth, smile design became accessible to all people, actually. And that's why I appreciate this technique. But unfortunately, it has its own limitations. Eventually, you go to the commercial software, so professional dental software companies which are releasing smile design software. You can look into these kinds of software. But the problem is obviously the huge payments which are asked for these kinds of software. So here's Mira again. You have to appreciate what's happening right here. So the DSD did not work, and we needed an alternative method to increase the length of her central incisors and to perform bleaching for the rest of the teeth. So this is the PSS. Right here, you can see that we were able to lengthen the centrals. We were also able to move transitional line angles. In this technique, you can simply hold a brush and paint the teeth if you want to simulate a bleaching treatment. This is not available in PowerPoint. And that's why I say that the software is really powerful. But again, the problem with Photoshop is that you get into this software and you will be overwhelmed with the tools that you can see. You cannot choose the tools correctly. So here's the before, after. I then copy some transitional line angles. I can even move these transitional inside of, maybe to widen a tooth or to make it look slimmer. We can play around with the line angles in this software. So this was the initial, okay? This was her initial. I performed the first PSS, and I show the result if we only put composite, for example, on the facial surface of the teeth without lengthening the central incisors. I then show the second simulation with lengthening of the centrals. And then I show the third simulation with bleaching of the teeth. So if we were to look at it again, that was the initial. This was the first simulation. This was the second. And this was the third. So right now you have 3 designs or 3 simulations for 2 teeth tailored to that patient's need. You don't have to get those templates and start to align them on top of the patient's teeth. Patient then sees those pictures, and of course she opts for the third option, which is simply 2 restorations on the teeth and bleaching for the others. I start with a preoperative shade registration. As you can see in this picture, I said I will go off topic during the presentation, and this is one of the times where I'll go off topic. You have to appreciate the power of good dental photography and the things that you are able to see when you perform this kind of photography. In this picture, you can very clearly see the effect of the erosion and the dentine which is present and exposed, and the way it's softening, which could indicate a really quick progression of the disease and the need for a quick intervention. And I think in this case, I've performed the most conservative way and the most conservative treatment. A really non-conservative way of executing this case would be full mouth rehabilitation or 10 upper veneers. That would be the worst way for a young patient. So the treatment was really conservative, simply bleaching of all the teeth and then 2 composite restorations on the central incisors. Now, why composite? The reason is that I don't want to prep the teeth. I don't want to remove undercuts. I don't want to create a really well-defined finish line everywhere for my lab technician. I want it to be as conservative as possible, and this is where the composite shines. This picture shows you the result after sandblasting immediately. No prep whatsoever. I just sandblasted the teeth. Again, you can see something simulating or looking like a finish line, but that's due to the erosion. After sandblasting, you can look really at the tooth surface and you can see how dull it looks. And that surface, the dull surface, is just a perfect surface for bonding. When I see this, I'm really happy and satisfied. As you can see, this is the result, sandblasting and then applying the retraction cord. Of course, you can apply a rubber dam in this case, but it was not possible due to certain reasons. Clinically, it was not possible. Of course, the Teflon on the neighboring teeth is so important in this step, and it prevents the etching gel from reaching the neighboring teeth. I recommend its use to everyone. It's really amazing. You get rid of the common problem of composites sticking to neighboring teeth and then having to remove it after that. You know, another really beautiful picture that I love to show. For those of you who are interested in bonding, uh, that's how bonding should be performed. The, the adhesive should be placed on a really dull surface. And after it's placed, you have to see that the spot on which it's applied is really shining. And again, it's very difficult for a person to observe this phenomenon if he's not working under magnification. And again, that's another topic, but I seriously do believe in the importance of magnification. With your naked eyes, you cannot see this view. This is the first layer of composite to just lengthen the incisors. And by the way, just regarding the magnification issue, I hear this comment a lot. They say that I hear it a lot. If you start to work with magnification, you won't be able to work without it, whether loops or microscope. You cannot go back to looking with your naked eyes. You will see nothing. And you know, that's partly true. But the reason is not eye damage that happens after using magnification. The reason why you can't go back to working with your naked eyes is that when you got used to this amazing way of seeing teeth in big proportions with such clarity and really observing every step of your procedure and how it's being executed, you feel like the old way of working without magnification, the way you used to practice, is really bad. And that's why most people cannot go back to working without their loops or without their microscopes. It's not because of loss of eyesight that happens after a person gets accustomed to magnification. I will tell you, it's not because you got accustomed to your magnification. It's because you got accustomed to high quality of work. That's why I really recommend utilizing magnification to everyone. The composite is then, of course, it's applied. Glycerin gel is applied on the final layer, and we light cure through glycerin gel to get rid of the oxygen inhibited layer. Now, again, you can avoid this step or not do this step if you are doing lots of finishing and polishing at the end, because the oxygen inhibited layer is going to form on the surface of the teeth. And if you are going to polish and finish lots of finishing for the teeth, it's going to be removed anyway. But it never hurts to perform this step just to make sure. This is the final result. As you can see, no more erosion showing on the central incisors. The teeth, they look nice. I think that's a nice smile. If I wanted to show you this and compare the final result to the simulation which we have performed before, they look quite similar. And the reason why they look quite similar is because of the reliability of the method. So I'm performing the simulation on the software, and also I'm performing the composite freehand. This is not the case when you are just putting the template on top of the teeth in the simulation and then doing freehand clinically. So the simulation should usually simulate your clinical procedure. And that's why I would not recommend using the template when you want to show the patient the results of a composite restoration or of a gingivectomy. I do not recommend putting templates on top of teeth to show gingivectomy. By the way, the patient's comment was that the final result was even more beautiful than the simulation. And that's what you usually want. You want a nice simulation, but you want better final results. So, happy patient. I can say partly because of a reliable smile design, because maybe without a smile, I'm sorry, because of a reliable smile simulation, maybe without the smile simulation, the patient wouldn't have underwent the treatment. Maybe she would have sticked with her original teeth, and the erosion and the disease would have continued to progress. That's why I really like these kinds of cases. Now, the second clinical case is that of a gingivectomy. You want to simulate a gingivectomy. How are you going to do that with regular digital smile design? In Photoshop, you can utilize the ruler, and you can calibrate the real measurements of the central incisor, for example, to the measurements on top of your ruler. So in this case, it's an 8.5 or 9 millimeter central incisor. So you just increase the size of the ruler to match that of the central incisor. Then the really nice thing with Photoshop is that you can draw those bleeding points. And right now I'm drawing them in white and not in red, because white is more prominent and you can visualize it easier on pink gingiva. So if I want a millimeter, I would just increase a millimeter and put that bleeding point. Or if I may say, the virtual bleeding point. I think this is a really nice and innovative method. So after I just put my bleeding points, I can simply go to the liquefying tool and stretch the teeth upwards towards this bleeding point. This is really amazing. I think this is the best method to simulate a gingivectomy. And I'm not being a fanatic like the Apple Samsung people. No, I'm not doing that. But you can really notice what difference it makes to be able to use this tool and simply increase the length of the teeth virtually. Because the traditional method would be getting those templates and putting them on top of the teeth and the gingiva to simulate a gingivectomy, which again does not resemble reality. So what is the use of a technique which you utilize to simulate reality when in reality you are going to perform something completely else? So after you stretch out the teeth, we can show the patient the initial picture, the PSS with a gingivectomy only, which is the second picture to the right, and then a PSS with a gingivectomy and bleaching. So we can show the 3 pictures to the patient, and we can let the patient choose. Of course, usually the patients always choose the bleaching because the teeth look really better. So this was our initial. This was our gingivectomy, PSS. This was the gingivectomy and bleaching. This was another picture of the initial, and this was just directly after the gingivectomy. So we are done with the first 3 points. Right now, I'm going to show you the 4 tools to perform the PSS. As mentioned before, these tools are there for you to try out and to work with. And if you want, you can ask me later on and type me an email if you need help with something. But these things, they need training. You need to train on these things. Photoshop is actually a very complicated software, but I've tried to limit it to 4 tools. So you just have to go find those 4 tools in Photoshop and have your first try with a smile. And if you would have any questions, I would be really happy to help later on. So the first really amazing tool in Photoshop, that's called the liquefy tool. So the liquefying tool is going to allow you to move things. You know, you've seen those pictures of ladies trying to make themselves look slimmer on Photoshop, and then you notice that maybe there's a car inside of that lady's waist, or a table which is stretching inside of her arm. This is the reason. Because of this liquefying tool, you can move things. Now, sometimes you can move 2 things at once, and that's when some of the problems happen. But with very simple training, you will be able to move those teeth or even the gums accurately. So in this case, this is the liquefying tool. Also, if you remember a few slides ago, the case with the gingivectomy, moving the gingiva upwards was also performed using the liquefying tool. So this is one of the really most powerful tools available because it allows you to move things. So the second and very important tool is the stamp clone tool. And what this stamp clone tool allows you to do is basically copying texture from one tooth to another. So after copying the texture right here, you can see that, again, I'm using the liquefying tool to move the teeth, to move the transitional line angle. So the stamp tool is a really powerful tool because it allows you to replicate texture. The third really important tool is the healing tool, and to show my patient what the result is going to look like if we remove this erogenous lesion, I've had to use the healing tool. And you know, the healing tool is the one used to remove pimples. You know, you go to a photography studio, all of them will be using Photoshop right there. After you take your picture, you get out, you feel like you have makeup on. It's like that photographer have just applied makeup on your face. So this makeup is usually because of this healing tool, because it mixes neighboring pixels together in the picture. It's a really powerful tool to hide certain problems in the teeth. And it's really effective when used in conjunction with the previous tools. So finally, the fourth and most simple tool is the painting brush, where you simply choose the white color, decide on the opacity. You would decide how much you want to lighten those teeth up. Do you want to lighten them by 20%? You would go ahead and choose 20% opacity, and this tool is going to lighten up the teeth. Unlike other software, where when you paint over teeth, you are covering them with a white color. In this case, the really nice thing about the brush tool is that it changes the color of each pixel alone. So what started as dark will still stay darker by the end of using the brush. Therefore, the teeth will still look natural. The cervical parts of the teeth will stay natural. The interproximal areas, which have to be darker usually, they will stay darker. And that's why the brush is really important. So basically, those are the four tools. If you use those 4 tools, You can perform any smile simulation you want. You can perform enameloplasty if you want to straighten up an incisal edge. You can perform a gingivectomy. You could perform a virtual composite restoration. You can test the position of certain transitional line angles if you want before starting the treatment. Maybe you want to make a tooth look slimmer. Maybe you want to make a tooth look wider. You can test that on a composite restoration before you even begin. These are the things which other methods don't really give you. So usually what they give you is a template, and you can play around with that template to perform, for example, 10 veneers or 8 veneers. Again, these tools require practice. So what I just gave you right now is simply the key. And what you need to actually be proficient at this is to try it one time, maybe find out you have some problems. If you have some problems, you could try to fix them, search the internet, okay? You can get in touch with me. This is my email. And I would be more than happy to help. Again, thank you. Hope this wasn't long. Again, thank you, IIDS, for inviting me. And I would be ready to take any of the questions. Thank you.
Thank you, Dr. Abyad, for the wonderful lecture. It was very, very interesting and very useful. Super practical tips. So I would like to go now on then to the questions, and for sure we will be waiting for additional ones as well. So the first one is that do you tend to use mostly composites in all of your cases? Let's say also when the cases are bigger, let's say when you enhance the vertical dimension, or you do some molars and some back teeth, or some bigger restorations? Or do you also use like kind of mixed techniques with ceramics and sometimes also resin composite?
Yeah, exactly. So each case is basically different. In this case, the patient was young. I have only a problem in the two centrals. I don't need to prep the teeth. I don't have caries. So composite right here is really an amazing solution especially for a young patient. But in other cases, when you have multiple class 3 restorations, multiple composites, discoloration of the teeth, it's much better to do ceramic veneers, obviously. On the back teeth, on the posteriors, sometimes if we are playing around with vertical dimension, I play around with composite much better than ceramics posteriorly, especially on those kinds of cases. To raise the vertical dimension with the ceramics is slightly risky, because when you're raising the vertical dimension, you want to make sure that you have no problems, the patient's happy, and usually if you want to do some adjustments, composites really easy to adjust. You can also do it without a prep. So there are various methods right now to simply use an index, a transparent silicon index, for example, and to raise the bite really accurately and precisely without preparation of the teeth, which is a very big advantage to when you use ceramics and you have to prepare occlusal onlays, for example, if the rest of the teeth are good, or if they don't need or require a crown. So I think my answer to that would be it's case dependent, but you should always consider composite in young patients as an excellent way to enhance aesthetics as well as function if you are intending to raise vertical dimension.
Okay, thank you so very much. And the second question is that how do you also work tightly with an orthodontist, and how do you have a lot of referrals also where they go before to the orthodontist and then you do the aesthetic part?
Yeah, so here's the thing. It's very common to do aesthetic work after ortho. It's much common. It's much more common than you think. And yes, unfortunately, if you're not an orthodontist, it's very difficult, and you cannot treat your own cases. So yes, the cases are referred to an orthodontist, and usually what happens in aesthetic dentistry is you get referrals after the orthodontist is done. So either the orthodontist refers that patient for example, gap closure when there are still gaps after treatment, or for example, for veneers when you have some problems or caries and discoloration with multiple composite restorations in the anteriors. The orthodontist might refer that patient, and at various other times the patients just leave and they want to enhance their aesthetic appearance after finishing the ortho treatment. Maybe they are not satisfied yet, so they seek they seek an aesthetic treatment.
Okay, and thank you. And the third question is from Raja Antar. So how can you bring the color you used on Photoshop as close to the natural color, whether it's composite or teeth? I'm not completely getting the question, but as I understand, it's like, how can you, with the Photoshop, then how can you bring the color as close to the natural tone that you want?
Yeah, I understand. That's a really great question, and here lies the original problem of 2D to 3D smile design. The color is not an issue as much as, you know, other cases where you are utilizing big templates, you are performing complete mouth rehabilitation on, you know, digital templates on the computer, and then you go to mill those restorations and it's a completely different design. So this is a problem when you are working with you know, 2D, whether with design or even in this case it's just the color. So basically you have to rely on your sense. You have to rely on your clinical sense. You have to imagine how much whitening you are going to get, and simply setting the opacity tool to that level. It's just by experience. But I think that maybe with some research into those tools, you can develop a more methodical way of adjusting the opacity tool to mimic real changes in teeth whitening. So at various times you move from an A2 Vita shade to a B1, for example, Vita shade by, or an A1 in bleaching, and maybe you can relate this change to a certain opacity setting within the Photoshop treatment. So I think that's for future work, but currently it really relies on your clinical sense.
Okay, thank you. Very, very interesting. And also, I would like to then finish or close up with some of the comments that we have received. They're quite nice. So Julia Juni says, "Thank you, doctor, from BAU students. Great lecture." Then Mazal Lama thanks you. Ismail Bahma thanks you. There's a thank you from a Vietnamese student, so quite far away. Also, Panis Hobby and Julien Issa, thank you very much for the lecture. And once again, a huge thank you from my IDS, and it was a wonderful lecture. Thank you.
Thank you so much for having me. I salute also all my BAU students, and I thank you for taking the time to listen to this presentation. Thank you.
Thank you.